So welcome everybody. Today I'm going to be talking about sleep apnea diagnosis and treatment. I think, I've given a few talks on sleep apnea to this group in the past. I think I've mostly sort of covered outcomes related to cardiopulmonary disease, but not really how do we diagnose it and treat it. So I thought, going over that at sort of a more basic level, might be important, for our group. So today I'm going to review the pathology and consequences of sleep apnea. I'm going to discuss some of the PSG basics. This is a talk I actually give our fellows, but so it includes a lot of the EEG findings, which we'll kind of run through kind of quickly, and then just talk about current diagnostic recommendations and review what treatment options are out there. So what is sleep apnea or obstructive sleep apnea? Sort of on this basic level, with obstructive sleep apnea, it's repetitive airway closure. But when you talk about sleep apnea or sleep disordered breathing, I mean, there is this sort of spectrum of what happens when we sleep. So you can have obesity hypoventilation syndrome where, not only are you having hypoxemic events and, apneic events typically, but, just the obesity changes that happen, in respiratory mechanics, hormonal changes, alterations in your respiratory centers actually leads to chronic CO2 retention just related to obesity. Shane Stokes respirations, which I think if we have time we'll go through, is kind of a special type of sleep disordered breathing where you have crescendo, decrescendo breathing and periods of central apnea. You can have pure central sleep apnea, which is instead of this repetitive airway closure, there's no, signal from your brainstem saying breathe. And complex sleep apnea, which we define a little bit more as treatment emergent central apnea now, and that has more to do with PSG findings. And someone on a diagnostic study may have pure obstructive events, and then you treat those obstructive events and see central events. We grade sleep apnea severity when we're talking about the obstructive sleep apnea based on the apnea-hypopnea index. And that's essentially how many respiratory events per hour are you having? So greater than 30 is severe, 15 to 29 is mild or is moderate, and then less than 15 to 5 is mild. And then there's some debate on this upper airway resistance syndrome where people are having respiratory events that don't necessarily quite meet the criteria we'll review for an apnea or hypopnea. They do seem to have like fragmented sleep and things related to that. But that's sort of there's some debate about that. So actually the pathogenesis of obstructive sleep apnea is fairly complex. Even there's a lot more to it than just being overweight and your airway collapsing. This was a paper by David White, which really sort of described the anatomic features of sleep apnea. And it's really this relationship between things that promote airway collapse and things that promote airway patency. So things that promote airway collapse, having a small mandible or being a little retrognathic can really impinge on that posterior lingual space. What we see a lot of in West Virginia, and unfortunately, as the obesity epidemic increases, is fat deposition, particularly the lateral fat pads of the neck, which really just put a lot of pressure on the upper airway and portend collapse. Then we have things that promote airway patency. So your pharyngeal dilator muscles, with your most, important being the genius glossus, and we'll talk about that later. And then your lung volumes. And essentially what happens is when you take a breath, there's some tug by the trachea across the upper airway that puts traction against, that upper airway and maintains patency. But what we're finding is there's a lot more to it than, just these sort of anatomic things that drive, obstructive sleep apnea. People who have more fragmented sleep, alterations in respiratory control, even outside of central apnea, can actually contribute to obstructive sleep apnea. And this is all sort of mediated by environmental factors and genetics. And this is the Sterling resistor model that was developed just to sort of describe what happens in obstructive sleep apnea. I don't think you guys really need to go through this whole thing. The punch point is P crit, or critical closing pressure, is the pressure where the airway closes completely during sleep. And we can actually measure this in the lab using a modified CPAP machine. So, just a way to think about it is, people with obstructive sleep apnea need positive airway pressure to maintain airway patency with a CPAP or BiPAP machine. If you're studying someone normal, you actually need to generate some suction or negative pressure to actually drive airway collapse with one of these devices. And so, normal people have a P crit of like -10. People who snore maybe to -10 to 5. And when you start seeing airflow limitation, significant airflow limitation, your P crit's usually 0 to -5. And then, obstructive sleep apnea, you get more positive P crit. So you need to overcome that. And, obstructive sleep apnea is important. There's, what really drives, and, the epidemiologic data has really kind of bore out that it has a lot of health consequences. And, some of it's driven by sleep fragmentation and arousals that happen throughout the night, leading to, increases in these inflammatory mediators. And one thing we really see in sleep apnea is their sympathetic tone is very high. So this has a lot of cardiovascular consequences. And then there's also chronic intermittent hypoxemia, which with increased oxidative stress, and again, affecting these different pathways, and again, contributing to sympathetic activation in the inflammatory pathway. So this is one of the studies just looking at long-term outcomes. This is Wisconsin sleep cohort. This was like 1,400 public employees who, as part of this study, they said, hey, you guys want to do a sleep study? And, 1,400 of them said yes. And then they got a letter in the mail just saying, these are your results, do with them what you may. And so what you can see here is you start seeing maybe a sort of uptick in mortality at that moderate severity sleep apnea range. And then, really once you're in that severe range, that's where you really start getting worried that patients are going to have a bad outcome. And this is important when we're, really considering management of these patients. And there's a similar study, the Sleep Heart Health study, which showed pretty similar findings. And they've done a lot of work. Susan Redline's group at Harvard's done a lot of work too on that. If you guys are interested, and they've studied a lot of specific cardiovascular outcomes, heart failure, atrial fibrillation, things like that. So diagnosing sleep apnea. So some of the symptoms of sleep disordered breathing, obviously snoring is one we hear about a lot. Probably up to 30% of the population snores, but not that many people have sleep apnea. So it's a very non-specific finding. Witness apnea is where a bed partner may say, it sounds like they start breathing or they're choking and gasping at night. Morning headaches, dry mouth, depressive symptoms. Women a lot of times will complain actually of insomnia, that they'll go to sleep fine, but wake up throughout the night. And that's, women have a much lower arousal threshold. So when they have a respiratory event, they tend to wake up from it and recall that, whereas men don't. Nocturia, difficulty sort of concentrating, particularly at work. Someone might complain of difficulty staying on task or remembering what they need to do. Probably the most predictive, none of these in of themselves are that predictive, but the most predictive is awakening, choking, and gasping at night. This is the relationship of sleepiness to sleep apnea. And this is a really important study showing that not all even severe apnea patients with apnea are sleepy. So there's a really, I showed you that good correlation between apnea severity and health outcomes, but we don't see that as strongly as far as symptoms go. In this group of sort of your non-sleepy sleep apneics who are in this severe range, that's a really difficult group of patients to treat. And what we're finding is we're getting a lot better at sort of clinical phenotyping and physiologic phenotyping. And it's turning out that maybe symptoms actually are fairly important. So, we may find, I couldn't tell you this yet, but we may find someone with a AHI of 40 in that severe range who's non-sleepy, has less of a health risk down the road than the same patient with an AHI of 40 who's actually symptomatic from their disease. But that's some work that's going on currently. But again, there are typical findings we'll see that, lead to, that you might find on the physical exam that may lead to, a question of sleep apnea. One is having sort of a crowded and high arch palate that really decreases that upper airway circumference. As I mentioned, in the intro, retrognathia, you can see how the jaw is really kind of set back and it really impinges on this retrolingual space here. So there's essentially less area behind the tongue. And you can see this, or it can be suggested if you see significant overjet or overbite, that would suggest that perhaps the mandible is set back a little far, and there may be some upper airway compromise from that. Tori, sometimes people don't even know they have these. This is, an example of a fairly large tori, and this can just cause turbulent flow, and again, decreased upper airway circumference, leading to apnea. And this can also have treatment implications, particularly like if you wanted to use an oral appliance or something. This might not be the optimal patient unless they were willing to undergo a surgical procedure. Large tonsils, this is what we see a lot in kids. You can see how there's no way any air is getting past those tonsils, right? Sometimes, we even see this in adults. I will say, historically, pop a kid's tonsils out and they're better from their sleep apnea. But unfortunately, what we're seeing, particularly in West Virginia with the obesity epidemic, it's really hit the pediatric population now too. So a lot of kids have their apnea driven more by obesity than these, than upper airway lesions. So instead of having curative surgery, a lot of times they're actually having to go on CPAP as well. The Mallampati classification, this is, just how much of the posterior pharynx you can see. This was developed, in anesthesia to, predict how difficult an intubation will be. But there's some weak correlation between the Mallampati classification class and, risk of apnea. I usually ask a modified Mallampati where they keep the tongue in the mouth because that's how they sleep. But this is looking at the relationship between Mallampati score and AHI. So you can see there's, certainly a trend towards more severe apnea with, more airway compromise. But again, when you look at the confidence intervals, there's a lot of overlap. This is just tonsillar grading. This is something that an ENT might use when they're looking at the tonsils and deciding whether they need to come out or not. And again, looking at sort of your normal, see this sort of black behind the jaw here. That's a really nice patent airway. And then, someone with retrolingual and really retrolingual compromise, you can see how that gets a lot skinnier. This is just like your flow volume loop, and you can see in the expiratory limb, you just have this sort of sawtooth pattern, and that's just from floppy upper airway. So, non-specific finding of sleep apnea. Risk for obstructive sleep apnea is, increasing neck circumference is sort of classic one, with 43 centimeters in men and 40 centimeters in women. And, when you look at our local Caucasian population, a lot of sleep apnea is driven by obesity. So what we see sort of throughout Appalachia is really obesity. When you look at sort of the, Asian populations, a lot of times it's more craniofacial features and less obesity that drives obstructive sleep apnea. But when you look at, if you just looked for your classic big guy with a large neck who snored, you'd really miss a significant portion of the cult OSA in the general population. And there was a big article just published within the last year suggesting there's about 1 billion people worldwide with sleep apnea who are, undiagnosed, and that number's probably getting worse as our obesity rates just get higher and higher. So how do we diagnose people? So the kind of gold standard historically has been polysomnography. That's where you actually have to come into a sleep center, get hooked up with an EEG and, a number of different leads measuring, respiratory effort, looking at, movements at night. And we look at these different EEG findings to help stage and score, the different sleep states, whether it's wake, stage N1, N2, N3, or REM. And this is kind of your standard montage we look at when we're looking at a sleep study. So again, someone just comes into the sleep laboratory, and we monitor these different signals during the night for you guys with those. But what we're talking about today is really scoring these respiratory events that occur. So we score an apnea if there's a drop in airflow, which we're measuring by a thermal sensor for at least 10 seconds. So I'll show you examples of these. So an obstructive apnea occurs when there's no airflow but ongoing respiratory effort. A central apnea occurs when there's no airflow, but there's no respiratory effort. And then a mixed occurs when there's absent inspiratory flow during the initial portion of the event with no respiratory effort. And then the patient starts trying to breathe again, but there's not immediate resumption of airflow. Then the other respiratory event we do score is a hypopnea. So you don't have as dramatic decrease in your airflow with a hypopnea. It still lasts 10 seconds, but it has to be associated with a desaturation. So your oxygen levels do need to drop. And then Shane-Stokes respirations is where you have 3 consecutive periods of central apnea separated by this crescendo, decrescendo breathing we talked about, and it has to have a cycle length of at least 40 seconds. And this is really more for billing. There has to be at least 5 central apneas per hour. And that's, kind of across the board if you're ever going to put someone on a, home device with a backup breath rate, most insurances are going to request that you demonstrate some sort of central apnea. There's actually a number of different respiratory events we can sort of score and look at, and based on what we score, we can develop these different indices, but I don't think that's something you guys need to know. Here you can see, look at this flow NO. You can see the sort of baseline expected flow here, and then there's these periods where there's a decreased airflow after these sort of high amplitude peaks. And in the sats down here, you can see the oxygen level is actually dropping. And up on the EEG, you can see how it's this, very flat, slower EEG. And after every one of these respiratory periods, there's an awakening. You can see this speeds up. And so you can imagine doing that throughout the entire night while you're sleeping. You feel pretty bad in the morning. Here, this is an example of a central event. So you can see there's sort of absent respiratory effort here with the rib cage and the abdomen, and in the abdomen, it's completely flat compared to where there's ongoing respiratory effort here. And then there's complete sensation of airflow. And this is more of a periodic biop breathing pattern, but again, it's kind of the same. And then this is your, Shane-Stokes respirations, which you get this crescendo, decrescendo breathing pattern where patients breathe in really, really hard and then kind of stops. And a lot of times will develop complete apnea here. And this really has more to do with CO2 homeostasis. So again, just to sort of summarize everything, absent airflow, you can see here with ongoing respiratory effort. This is a obstructive apnea. Here, no respiratory effort, no airflow, central apnea. And then here, absent respiratory effort, absent airflow. The patient tries to start breathing again, but airflow hasn't resumed. And a lot of times you'll see what happens. This is when you'll have your gas, maybe even wake up a little bit, and then you start breathing really hard, right? Because you haven't overcome that obstruction. So that full in-lab sleep study where we wire everyone up, as I said, was the historical way we used to diagnose obstructive sleep apnea. But now we use, a lot of times we'll just do portable sleep tests, which are really just a respiratory test. Patients will have, pulse ox on their finger at night. They'll have a respiratory effort belt, many times with the recording device attached. And then they'll have a little canister, almost looks like a supplemental oxygen in their nose that measures airflow. Essentially, when you look at their airflow, respiratory effort, and pulse ox throughout the night, and we'll identify respiratory events that way. So they might just wear this in their home to make the diagnosis of obstructive sleep apnea. And you can see from the signal here, it's pretty similar from the respiratory standpoint, what we're looking at in these patients. Again, you can see this patient's having absent airflow, ongoing respiratory effort, and there's some associated desaturations with these respiratory events that are occurring. So home sleep tests, we really use these in people with high pretest probability. So it's your people who you're really suspicious have obstructive sleep apnea, snore, feel really tired during the day, have, awaken at night choking and gasping. The ASM still recommends no significant cardiopulmonary comorbidities. So, bad COPD, heart failure, those patients typically need to come into the sleep laboratory. That we've actually been finding, with the COVID pandemic, we've been pushing this a little bit more because it's really an absence of data, not, adverse outcomes in those populations from doing this test. But I do tell people if someone's, a heart failure patient or advanced COPD patients on supplemental oxygen, they almost certainly need to come to the lab. And that's, again, compared to our full night attended study, who you're not maybe 100% sure, is it sleep apnea or something else going on? Do they have significant cardiopulmonary comorbidities or at risk for complex sleep disordered breathing? They might need to come into the lab. A lot of sort of frail people or more elderly people, maybe with dementia, that, performing a home test can be difficult for them. And I should state that if someone fails an in-lab study and or fails a home test and it's negative, presumably that's a high pretest probability patient. The recommendation is they actually come into the sleep lab. So for the last 2 minutes, I'm just going to talk quickly about treatment that's available. Every patient with sleep apnea should have a discussion of lifestyle. Fitness and weight loss can really help these patients. They should avoid sleep deprivation. That can actually worsen sleep apnea, as well as alcohol and sedatives. Some people have more of a positional component to their sleep apnea, particularly when they lay on their back. That tends to be when apnea is the worst. So, there are even these fancy devices that people can buy that like keep them on their side when they sleep. Some patients, one patient comes to mind, his wife just sewed a tennis ball into his t-shirt. And so when he rolled on his back, that tennis ball would aggravate him and he'd just roll back over. That was a pretty cheap approach. Obviously CPAP is kind of your classic standard treatment for sleep apnea, gold standard. And then we'll go through these other things. I did mention surgery. There's a number of different multi-level surgeries that can be done. But they really have to, I would say it really has to be in the hands of someone who knows what they're doing. We have an excellent surgeon here, Dr. Kutras, who that's all he does is, surgery for sleep apnea. So he really knows what he's doing. So CPAP, again, your gold standard or treatment, I would say still, it's not the optimal treatment for everyone. When you look kind of across the board, probably about 40–50% of people who go on CPAP love it, will never sleep another night without it, feel a lot better. But that's at least half of people go on CPAP, hate it, think it's cumbersome, don't want to be attached to this thing every night. You can maybe do some desensitization techniques, play with their pressure a little bit, use some comfort settings, and maybe get another 10–20% patients adherent to therapy. But that's at least a good third of patients who, there's no way they're going to use CPAP. So what do you do for these folks? Oral appliances is a good option. Even some patients with severe sleep apnea can respond well to an oral appliance. The biggest barrier to oral appliance, particularly in West Virginia, is cost associated with the oral appliance. Medical insurance won't cover this, dental insurance won't cover this, and then there's not, oral health in West Virginia is very poor. You need to have probably about 10 good teeth to having an oral appliance work. And, unfortunately, that's not the case in a lot of patients in West Virginia. Essentially, what these do is they jut the lower jaw out and kind of, increase that retrolingual space, and also put tension along the upper airway to sort of maintain patency. Dr. Non at WVU does a lot of our oral appliance devices. Some of the emerging therapies, I would say these expiratory nasal valves, the Provent, these are things that go at the end of the nose at night. They kind of just stick there, and they're a one-way nasal valve, so you can breathe in through them, but then when you breathe out, there's back pressure that sort of acts as a pneumatic splint to keep the airway open. These are actually extremely effective for snoring. I do have a couple patients with sort of milder degrees of sleep apnea who have responded well to these, but certainly like moderate to severe disease, these typically don't do the trick. I need to update this, but this oral pressure therapy really didn't turn out working. Then the new kid on the block is the upper airway pacer. This is the Inspire device. It's the only one that I know that's on the market right now, although the FDA just approved clinical trials and 2 other upper airway pacing devices that work a little bit differently. So there may be more coming to the market, but essentially, this is a neurostimulator. that goes to the distal branches of the hypoglossal nerve. And it really stimulates the genioglossus, or the tongue muscle, to protrude. Again, as I mentioned in one of those first slides, that's the most important muscle to maintain airway patency. And then there's also bulb coupling of your other pharyngeal dilators. And then that has this sensing lead looking at respiratory efforts. So, as the neurostimulator senses that there's these bigger swings in upper intrathoracic pressure as you're trying to overcome these this upper airway closure, the neurostimulator activates and maintains airway patency. So this is sort of baseline therapy where you can see someone's having a lot of airflow limitation, pretty bad desaturations. They turn on this upper airway pacer, and you can see this airflow limitation goes away. So we have a program here at WVU. Dr. Koutros puts this this Inspire device in for us at our program. They've actually pushed the severity of sleep apnea, so I think it's up to 60 or 70 now events per hour. They've also pushed this body mass index. This was a big limiting factor for West Virginia. So it should be a BMI less than 32. So your BMI had to be less than 32. I think it's up to 34 now. And really what's the most important determining factor is, our surgeon will take someone and do what's known as a drug-induced sleep endoscopy, where they use a propofol protocol to sort of simulate sleep, and then use a scope to go down and look at the upper airway and how it collapses. If it's collapsing in the AP diameter, that's a patient who's really going to respond well to this therapy. If there's more circumferential collapse, and as I talked about, West Virginia, what we see a lot of is those lateral fat pads in the neck really impinging on the upper airway. You get more concentric collapse, and it's not effective in those patients. So this is your Cheyne-Stokes respirations, and sort of the optimal treatment for that is to treat the underlying condition. What we see a lot is people with heart failure and neurologic disease. And as I showed you in that previous example, it really manifests by this crescendo decrescendo ventilatory pattern that occurs. And it comes back to this engineering term of loop gain. So, and in this exaggerated response. And why it happens in heart failure is there's actually a circulatory delay. That's why you have that 40-second sort of threshold. So you can kind of think about it, if your heart's not pumping efficiently, it takes, that red blood cell and, the gases in that blood, if it's circulating through your whole body, how long it takes to get from, your LV back all the way around to your LV. So there's a delay in sensing that there's changes in your CO2 and pH levels. And so that leads to alterations in your brainstem and responsiveness to CO2 levels. So during these crescendo periods, there's a heightened response to these changes, and you blow down your CO2 really far below your apneic threshold, and then you go apneic, and then your CO2 builds, and then you have this exaggerated response. So it just sort of self-perpetuates throughout this process. And so just so there is a difference between Cheyne-Stokes respiration and central sleep apnea. Again, Cheyne-Stokes has this typical crescendo decrescendo pattern versus central sleep apnea, which are just these central events that can occur. They typically don't have a prolonged cycle time like you see in Cheyne-Stokes respirations. Really, what we've seen a lot of central apnea from the opiate epidemic. Those are really, really difficult patients to treat. And sort of interesting is, even when patients come off opiates, it does seem, at least for a period of time, this central apnea persists. really their main complaint is arousals throughout the night, poor sleep, and feeling tired the next day. This is just a, kind of a more complex machine called adaptive servo ventilation we used to use in patients, particularly with Shane-Stokes respirations, but turned out we might be killing them, so we don't do that anymore. And then this is just a summary slide of the different types of PAP therapy that are out there, and then when you might use it, and when might be an appropriate patient. But I know I went over time, so I'll stop there.
Thank you so much, Dr. Stansbury. That was a really great overview, in-depth overview of sleep apnea and everything related to it. So we really appreciate it. Did anyone have any questions, comments, or thoughts for Dr. Stansbury? Feel free to unmute or chat in. Thank you.
Hey, Dr. Stansbury, this isn't necessarily physiology question, but more, the recall on the Philips machines. I have some patients that are saying that their insurance company won't even approve a new machine. What kind of help can I give them, or what?
Yeah, Philips put us in a really kind of bad situation, I feel like, because insurances aren't paying for them, and they've really been slow to sort of come up with a solution. For those of you who don't know, the big problem was this foam that was in the device that was trying to make it more quiet. It seemed to be breaking down, and the thought was, patients were inhaling this. Big risk for that is anyone who uses like one of those ozone cleaning devices like Soclean was a big risk for it. I tell patients, the most important thing is, one, they need to register their device with Philips. I think this happened back in beginning of June, maybe July, and Philips had people start registering their device. I think they were looking for a way to maybe replace the foam and not have to get people brand new devices. But what I've heard is they have finally started just replacing the devices. So they're slowly getting out there, but this happened at sort of the worst possible time with all the supply chain issues, so the company can't even get these devices in. I think there was something like 4.5 million boxes that they have to replace. So we sent out a letter from our lab, and I think a lot of DME companies did that as well. But when patients come in, I kind of just discuss the pros and cons of staying on their device. And I have had a lot of patients who don't have any of the side effects Philips warned about, and say, I feel so off my machine, I'm staying on it until they get me a new one. Now, I will say the one other thing to keep in mind: if someone has a device over 5 years old, sometimes in that situations, insurance will cover it. Not all, but that's one group that you might be able to get a new machine for.
And then you mentioned the Soclean device. What was the issue with that?
I think it was the interaction of that foam and that ozone that those devices use to clean it. It just led to more robust sort of breakdown of that lining. So those patients were at higher risk.
Is the Soclean device something that you support patients using? No. Okay.
No.
And why not?
Well, I think it was with, I can't remember which one now, but with the ResMed, I think there was actually, it was changing the colors of the tubing.
Yeah.
So there was some concern, maybe even that was, there was something there. Now, I don't think ResMed actually had any issues when they sort of looked at it other than this color change, but there was always some thought maybe there was some interaction. Now, when it first came out, I used to counsel patients that if you clean it well on your own, don't buy it. But, it was always like, you'd see these patients bring their machine in and their, water reservoir would have mold growing in it. So, that patient, maybe they would benefit from it because it's so easy, but, again, it's a risk benefit.
Okay. So best thing is just tell them to be good about cleaning their machine.
Yeah, exactly. But, I will say, I don't know if any of you guys have ever or have a CPAP or used one, but, doing a good cleaning job is actually a little cumbersome. So, you can see why one of these, devices would be something someone wants to use.
Rob, if you have the ResMed machine and you've used the Soclean machine, have they found any evidence that there's any foam breakdown with those?
No.
Okay, thank you.
The biggest thing is that the only thing is that some people's tubing turns orange, whether that's, bad or not, I don't know.
Okay, all right. Thank you.
I know we have another question. Before we get to that, did anyone have any other questions they wanted to unmute and ask or comments? And Dr. Doyle, I noticed you unmuted there. Did you want to ask your question?
Yeah. Well, first of all, I just want to thank Dr. Stansbury. That was I was feeling pretty physiologically challenged in terms of following all the physiology. It was an amazing spectrum of physiology. And so I had lots of different questions along the way, but I think the one that kind of struck me just clinically was about the contribution of sedatives and opiates that you mentioned in two different slides. And so in terms of the opiates, my question is what was the dose threshold where you started seeing that show up? Because and then my comment is that there's just a good publication that I sent out to our providers at Cabin Creek and New River on the lack of benefit of muscle relaxers in treating low back pain, which is an extremely common clinical practice, not only clinically, but for years and years and years. We see people on cyclobenzaprine 20 years after their back pain, along with 2 or 3 other sedatives that they're using. So that's just a comment, speaking of common clinical practice that does harm. But my question is about the opiate threshold dose where you see it start to make a difference.
Yeah, so, and I'm sure you're aware, there's different, there's people metabolize opiates a little bit differently. The way it really works, I mean, you're opening a big can of worms here, Dr. Doyle, but in your brainstem, there's kind of your sinus node of the respiratory systems known as the pre-Botzinger complex. And a lot of the work that I think it was actually done at Pitt found that there's tons of mu receptors on the pre-Botzinger complex. So the thought with the opiates and how it affects, this leads to these central apneic events is, they just saturate the mu complex on your sort of sinus node of the respiratory system and people stop breathing. But there is great variability. And some people, we've seen that actually come off opiates, their central apnea goes away. As you can imagine, very uncommon to see that clinically. And then other people, it persists. I think I mentioned that. And sort of one thought is that it's just these, there's just down regulation of these receptors and the sort of decreased responsiveness over time of the pre-Botzinger complex to really maintain that normal breathing pattern that occurs. So I don't think there's a particular threshold. Now, sort of interestingly, a lot of the physiologic work done at Harvard looked at, I think it was hypnotics, opiates, and I can't remember if they did the muscle relaxers as well. I mean, you would think muscle relaxers would be pretty bad, just affecting the pharyngodilator muscles. And what they found, we used to think that if you gave like someone with apnea an Ambien, I mean, you might kill them just because you're going to decrease their sort of output, their respiratory output through hitting the GABA receptors. But some of the work done at Harvard doesn't show it has a huge impact on apnea severity like we used to think. Now, it does affect people differently. I'm sorry I'm going on, Dr. Doyle, but just one other interesting thing that I find kind of fascinating is some people with apnea, it's really driven by this cycle of recurrent sleep fragmentation and awakenings. It leads to an unstable respiratory drive output. So there's actually a subset of patients that go on hypnotics and their apnea will improve, interestingly enough. When you look at the kind of big 30,000 foot view, in general, it worsens. But this gets really back into this, physiologic and clinical phenotyping of apnea that I think in the next 10 years, we're going to be thinking a lot more about.
Is the opiate issue limited to impact on central apnea?
No, so central apnea is the big driver, but it also, in general, will lead to some worsening of central or obstructive apnea, but not severe. I mean, we used to really worry about giving people opiates who have sleep apnea, but the impact's not as severe. Now, I will say, Dr. Sharma has done some work in hospitalized patients with sleep apnea that is undiagnosed, so untreated, and they screen patients in the hospital and identified those at risk for sleep apnea. And having sleep apnea plus acute illness and getting an opiate, there was a huge increase in respiratory event codes that was called and transfers to the ICU. That was published in Annals ATS 3 or 4 years ago. So that patient population, you really got to be careful.
Thank you.
Sorry, I ate up everyone's time.
Not at all. We really appreciate it. If anything, that's wonderful. So thank you. Any other thoughts from the group or questions?
Was there something in the chat, did you say?
We did, but I think it was asked already.
Okay. Dr. Doyle, are you back?
No, I'm still stuck here in California.
Okay. When will you be back?
Actually, I'm trying to figure that out right now. It's
Okay.
hopefully before the new year.
I had some things I wanted to talk to you about. Once you're back in town, let me know. I'd appreciate it.
We probably shouldn't wait. Maybe I'll just give you a call this week.
Okay.
Dr. Doyle, safe travels back when you do get to come back.
Thank you.
Alrighty, any other final thoughts or questions? I can give you guys 8 minutes back to your morning. Alrighty, well, thank you all so much, and thank you so much, Dr. Stansbury, as always. It's always a wonderful refresher going through that didactic, so we appreciate it. My only announcement is that our next session will be on December 20th, and Dr. Sharma will actually be joining us for that and providing the didactic on pulmonary embolism, excuse me. So keep an eye out for that reminder. In the meantime, if there are any questions, comments, or need help with submitting a case, just shoot Elizabeth and I an email. We're always there to help. So thank you all so much. Have a great week. Take care.